Hello, this is Leslie Deer, and you have reached my Histological Processes 2 senior project, which is a mystery diagnosis with histological implications. I want to thank Dr. Mary Iacoca of Christiana Care for providing the case study for me, and we're going to crack right into it. Our patient is a 56-year-old female with no obvious physical ailments, except for a slightly elevated blood pressure, which is fairly standard for a female of her age. She had recently been in not just one, but two near-miss collisions. It shook her up pretty badly, and she went to see her primary care physician um, because she couldn't quite get her head around what had happened with those accidents. She felt like she was being very attentive, and yet she still missed these vehicles, and quite frankly, it scared her. So her doctor put her through a series of visual tests, visual scans, and determined that she was very deficient in her peripheral vision. This worried him quite a bit, and he sent her right away to have a CAT scan. And the CAT scan revealed that she had a 1.8 centimeter mass growing on her pituitary gland. The pituitary gland is located directly behind your eyes and nasal cavity, almost in the center of the head. It's attached to your hypothalamus but dangles below your brain, and it sits in a pocket of the sphenoid bone called the sella turcica, which means little saddle. And it's protected on all sides by this bone, and it is divides your nasal cavity from your brain. Um, the pituitary gland is considered to be the master gland of your body. It basically sends out hormones and chemical messages to all the other glands in your body to tell them to either upcycle or downcycle their processes. And it works on a feedback loop to then adjust its own messages in regards to the status quo of your body. In order to understand how a growth on the pituitary gland can affect your peripheral vision, we're going to have to talk about this yellow structure, which is the optic chiasma. This is pivotal in transmitting neural images from your eyes to your occipital lobe, which is located on the back of your brain, towards the back of your skull. Um, the pituitary gland normally would sit on top of this little tree stump looking structure. It would be like a bulbous glandular looking tree, leaves, and branches. But they've cut it out here so you can have a good view of the optic chiasma. This structure is essentially a four-way stop from neural messages coming from your eyes traveling to your occipital lobe. Basically, you have a left and a right eye, and your left eye has a right and a left side, and your right eye has a left and a right side. What has to happen with those neural messages is the message that's coming from the left side of your left eye has to bundle together with the message coming from the left side of your right eye. And all of this sort of neural crossover and bundling and sending that information to the correct side of your occipital lobe happens right here in the optic chiasma. If you have some kind of growth or tumor on your pituitary, it will protrude up out of the sella turcica and start putting lots of pressure on this structure. And it effectively pinches off nerves that are your eye, messages from your eyes that need to cross over and bundle together to get to the back of your skull. The crazy thing about this is you might not notice this as a person with vision, because if your optic chiasma is being pinched off right in the center, you still have a left and a right eye. So the information that is supposed to be bundling with your left eye from your right eye might not be there, but because you have a left eye, that you won't notice that extra information is missing because you still have a full picture of what's happening, and it's that's where the confusion from our patient was coming from because she noticed something was weird about her eyesight, but she couldn't really put her finger on it. Was happening is the message that the broader message on each side was missing, but she didn't notice it because her other eye was compensating. Pituitary gland is made up of an anterior and a posterior lobe. The anterior lobe is the larger of the two, and it is responsible for all of the somatic hormones. Somatic meaning bodily. Things such as growth hormone, thyroid stimulating, which is involved in metabolism. Also, all of your female reproductive hormones, luteinizing hormone, follicle stimulating hormone, prolactin, which affects breast development and expression for when you've had a child, beta endorphins, and very importantly, ACTH, which is your adrenocorticotropic, uh, a whole range of adrenal responses. Your fight or flight response, and, and anytime you're in any kind of competition or a fight, all of those hormones are going to be kicking in. Um, and we're going to talk about those very specifically in a minute. Your posterior lobe, the smaller part of the pituitary, is mostly neural in nature. It produces some other chemicals and neurotransmitters, but also hormones that are involved in pain, oxytocin, and also antidiuretics like vasopressin, which is key to telling the kidney to hold on to water to maintain your blood pressure. Um, this structure, your pituitary, that both parts, the posterior and anterior, are very important. They're very closely connected, and they developed very early on in fetal development. And in fact, it's thought that they have in fetal growth, the development of each side kind of pushes each other to grow by sending each other signals early on in development. So it's really impossible to divide bodily function from neural function because they're two agencies controlling and affecting uh, your tissues. ACTH, your adrenals. Your adrenal gland sits on top of your kidneys, and if the pituitary gland sends it a message to kick in, boy, your stress response is going to go through the roof. Um, the adrenal cortex is responsible for uh, epinephrines, cortisols and androgens, aldosterone, and elevated stress levels for both the short term and the long term. Epinephrine is essentially stepping on the gas pedal. It affects your heart rate, your circulation. Cortisol and androgens is basically the gas. It controls metabolism, gassing up, testosterone levels. Aldosterone is sort of adds hydraulic pressure behind the gas. It affects blood pressures and your sodium potassium pumps. It gets those things like geared up. And basically, all those things are just kicking your system into high gear. People with anxiety probably have adrenal disorders. Um, just basically sets your body into fight or flight. It shunts blood away from the surface of your skin. It stops digestion. It changes metabolic processes. A lot of stuff is affected by your adrenal glands. And it can put your body in a state that isn't very healthy to be in on the long term. I mean, it's the whole concept of being frazzled is a result of your adrenals. Cortisol, which is one of your major adrenal hormones, can really cause a lot of problems, metabolic disease, if it's dysregulated. Your body starts to hold on to excess metabolic products and fat, and it will try to store it in abnormal places. You could develop a buffalo hump, which is a fatty pad on the back of your neck. Trunk fat with wasting legs or wasting appendages. You would think that if you're getting chubby, you're going to get chubby all over the place. But with cortisol disorder, um, you also have problems with abnormal amino acid synthesis. So your legs and your muscles will waste while your body is storing fat in abnormal places, places where your body can get to it quickly, but in the case of stress. But normally, your body would not normally hold that much fat in those areas. The moon phase can really change the appearance of a person. Um, and oddly enough, a lot of these presentations can be mistaken for normal middle-aged female development. You know, at a certain age, women put on a little extra weight. So and so might let herself go a little bit. And a lot of times it happens very slowly. It kind of creeps up on people. So they might not notice that it's abnormal fat storage until they start exhibiting other problems, such as hirsutism, which is abnormal hair growth on females, which also is kind of normal when estrogen levels dip. Menstrual disruption, depression, cognitive impairment. Um, Cushing's disease is when your pituitary gland specifically is responsible for the excess cortisol. Cushing's syndrome is when another part of the body, sometimes a tumor, sometimes polycystic ovary syndrome, could be creating a not a Cushing's disease proper, but a Cushing syndrome. Also, excess oral intake of steroids can cause a temporary state of Cushing's. That would be syndrome, not disease. But if it's linked directly to a dysfunction of the pituitary, that is going to be Cushing's disease. Now that we know we're dealing with a Cushing's disease proper, which is a result of the tumorous growth on the pituitary gland, how do we handle it? We're going to use a transsphenoidal endoscopic approach, which is actually the least invasive type of brain surgery that can be performed. The surgeons will go in through the nose and nasal cavity and drill through the thin bones of the nasal sinus, up through the sphenoid, which also has a lot of open sinus areas, to reach the pituitary without breaching any other part of the brain. Most of the pituitary tumors are benign. That's a normal kind of situation. So a lot of times, all you have to do is go up there and snag that tumor out, and hopefully you get all of it while you're in there and it doesn't grow back. There are times when it does grow back, but it happens over a long period of time. And there are medications that can be used to control the tumor growth over a larger period of time. So It's not like someone's going to go back in 2 years and have another brain surgery. They're going to do everything they can to sort of like push the surgery back as much as possible, as long as they know that it's not a cancerous situation. Actual photographs of a pituitary tumor excision. Top right hand corner, you can see the tumor, which is that buttery yellow mass. Um, it's being held in place by some little capillaries. Bottom left hand side, you see the resected tumor on its way out. They've got a grip on it and they've trimmed it away and they're pulling it forward. You can kind of see how big it is. And bottom right is that area that is now clear and clean. You can see the optic chiasma towards the top. It's the whitish looking material compared to the buttery tumor. If you look at the top again, you can see how closely that tumor was growing in relation to the optic chiasma. And if you imagine that space being compressed back down as it is normally, you can see how uh, that structure could be definitely putting a lot of pressure, filling up that little space in between the top of the pituitary and the bottom side of the optic chiasma. Now that tumor's out, we have to get it on a slide and under a microscope so a pathologist can make a formal diagnosis of what they're looking at. First of all, they have to determine if it's cancerous or not, because that's a pretty big deal. If it's cancerous, there's going to be another round of treatment. And they need to be sure, they need to know if the cancer is of neural tissue or somatic tissue. They really have to identify. Um, those two tissues take greatly different treatments when it comes to cancer. And so they really do have to get in there and since they are so intimately entwined and connected, morphologically, it's not going to be really obvious if they're looking, what type they're looking at. So they're going to have to hit it with a histological stain in order to differentiate the tissue types. Here are a couple more views of a pituitary gland. Top left is a cross-section and macro view of a pituitary gland. And knowing what we know now, it's pretty easy to ID posterior versus the anterior side of those two lobes. But that's not what you're going to be looking at under the slide. You're going to be looking at the tumorous material that was removed from the pituitary, and it's not going to be obvious. It's going to be a bumpy, lumpy piece of weird tissue that isn't necessarily shaped any particular way. You're not really going to have a good idea where it came off of, even though they do take pretty good notes. What you're going to see on the slide is going to be more in line with what you see on the right, which is the same piece of tissue treated with different stains. The first one is on the left is a typical H&E, and that's the first stain that happens with everything, and there's no way to ID the difference between the neural material versus just your regular glandular or your somatic material. They hit this with a PAS orange G, which is periodic acid Schiff with orange G added, and that obviously differentiates the two different tissues. One is clearly orange, the other is clearly a dark red, a reddish pink. And whichever tissue is showing the morphology of the cancer and is also showing up either orange or dark red, then you're going to know what type of tissue is actually cancerous. Here are a couple of different views of pituitary. On the left hand side, we have the conjunction between a posterior and anterior lobe, and you can see in the center those different types of material really are mixed up together, and they've grown together very aggressively. If you imagine all of those little dots as being the same color, you wouldn't be able to distinguish the ones that are showing up as orange from the ones that are showing up as pink if they were all either orange or all pink. It's really, the stain itself is very important here, and this is where histology comes in, because normally those things would all look exactly the same. To the right-hand side, we have two slides of the same tissue. The one on the left is a PAS orange G, and the one to the right is an IHC. That's done to detect ACTH. So when you have the same slide uh, that is indicating the same areas, um, then you know that you're testing for two different chemicals that are showing up in the same spot. So in this particular case, this glandular material is producing ACTH. The same tissue that is cancerous is also showing up as being producing ACTH. Once a pathologist has determined that they're looking at cancer, they're going to order back for panels depending on what they think it is. And those panels are never like one or two slides. They start off at like 6 or 8 slides and can go all the way up to 28 and even more, just depending on what they're looking at. They're usually between 8 and 16 slides that come through almost automatically. It's just a protocol. And what they're doing is they're playing like an extended game of multiple choice, because it's never you do test A and B and then so you know it's C. It's more like you test for A and B, and if it comes back A, you test for C, D, and E, and if it comes back B, you test for E, F, and G, and maybe a J. And it just it goes on until they have all of their questions resolved. And sometimes they have to do it more than once. Sometimes they want multiple sections to be looked at. They got to make sure they get all of the cancer, so they'll be doing um, multiple level checks. Pathologists have a lot that they have to look at. Their job is definitely not easy. But this is just an example of a couple of panels on different types of tumors and what the results look like with different reagents when they're tested with different types of stains, and different types of cancers respond differently to different types of stains. Here's our original patient post-surgery. She's been on hormone replacement for 6 months, just to keep her balanced until her pituitary heals and is able to produce hormones at her pre-surgery level. Her symptoms have subsided and her appearance has returned to normal with very little work. She actually hadn't gained any weight intentionally or accidentally. It was all chemical. It was all dysregulated hormones. So, lucky her, right? Yay. Um, like I said, hopefully she won't relapse. A lot of times, they don't have any additional problems. But if it does grow back, they will treat her with medicine until her symptoms are too severe, and then they'll go in and do another resection. But until then, happy her! Yay! Thanks for listening. Thanks for showing up and listening. Yeah, thank you.